medcram.com.
Well, welcome to another MedCram lecture. We're going to talk about the second half of rhythm in our rate rhythm axis. And we're specifically going to talk about blocks. So blocks prevent electrical conduction. So what I've got drawn here is an overview of the electrical conduction of the heart, which we've talked about before. And specifically, we're looking at the SA node, the AV node, the right bundle branch, and the left bundle branch area. And specifically, we're going to talk about blocks in those areas. Now, you may notice here that there is an anterior and there is a posterior branch of that left bundle. And so we're also going to talk about hemiblocks. But this is kind of a generalized overview of all of the different areas where you can get blocks. So you've got to know what those look like. We're going to expand significantly on this AV node, which is right here, because there's different levels of block. Okay, there's something called a first degree, a second degree, and finally a third degree or complete heart block. So let's take a look at those so you will know and see examples of the different types of blocks. Okay, so let's start with the SA node. So with a block in the SA node, there is some feeling that the SA node actually generates electrical activity, but it just can't exit the SA node. And so what happens is, with the lack of any type of escape rhythm, there is a lack of a P wave, because we know that the P wave comes from the SA node. Okay, so here's an example of a SA node block. You can see clearly here that we've got P waves, and then nothing, basically no activity whatsoever. And the approximate time period is about 800 in terms of milliseconds. And here we've got about 2500. So that's about 3 beats that were missed, and then it resumes back up and comes back down to about 800. And so you can see here what's missing is an entire P wave. And this goes on for a couple of seconds, and there is no escape rhythm. Sometimes you can have an escape rhythm, sometimes you might not have an escape rhythm. And the escape rhythm could be ventricular, it could be atrial in this situation. So that is an example of a sinus node block. So the thing that I think you ought to know for the SA node is specifically that it's the same timing and the P waves looks the same. They're the same distance from the QRS complex, pretty straightforward. Okay, let's talk about AV node blocks. So let's talk about the primary AV block, which is written as a 1 with a circle. So that's a first degree block. A first degree block basically just delays the communication between the atrium and the ventricle. So let's go back and take a look at the QRS and the P wave to show you where we're going to see that. So when looking at the P, QRS, and T wave complex, what we're looking at specifically here is we're looking at the PR interval. And that is from the very beginning of the P wave until the very beginning of the QRS complex. And so it is this distance here specifically that we are looking at. For there to be a first degree AV block, there has to be an elongated PR interval. Now the limit for this is 0.2 seconds, or one big box. Remember, the one big box has 5 little boxes inside of it. And one big box is equal to 0.2 seconds. So if for some reason the PR interval is longer than 0.2 seconds, by definition, or one box, you are going to have at least a first degree AV block. Okay, so let's take a look at an example here of an EKG. Let's take a look here at lead 2, which is probably the best lead to see P waves. And you can see clearly there's a P wave right there. And here, there's a QRS complex. And if we measure the distance from the beginning of the P wave, which begins right there, to the Q wave, the R wave, I should say, the QRS complex, which is right there, clearly we can see that that distance is bigger than one large box. Therefore, this is going to be a first degree AV block. Okay, so let's review. A first degree AV block is going to have a 0.20 second PR interval, or longer than a 0.2 second PR interval. And that's going to define our first degree AV block. A second degree AV block has 2 types, and this is where it gets a little confusing. There is 2 names for the second degree AV block. One of them is known as a Wenckebach, and that's otherwise known as a Mobitz type 1. Or there's a Mobitz type 2. So a Mobitz type 1, a Mobitz type 2. A Mobitz type 1 is also known as a Wenckebach. So just be aware of that confusion. For some reason, that's what they've done. Now, a second degree AV block has two types, as we just mentioned. The Wenckebach, or Mobitz type 1, actually occurs in the AV node. And so as a result of that, it is susceptible to parasympathetic innervation. However, a second degree AV block, that is Mobitz type 2, is actually below the AV node and has no input from parasympathetic fibers. The second degree is worse, and the first degree is not as bad. Usually the second degree AV block that is a Mobitz type 1 or a Wenckebach usually is transient and can go away. However, an AV block of the second degree that is a Mobitz type 2 is usually more permanent and usually has to be treated with some sort of pacemaker. And we'll talk about how to differentiate those two very, very shortly. But I want to make sure you are aware that there are two types of second degree AV blocks, Wenckebach or Mobitz type 1, and the more dangerous one is Mobitz type 2. So let's go ahead and take a look at what they look like. Okay, so here's a good example of what they look like. Here we have Mobitz type 1, as we mentioned, otherwise known as Wenckebach, and we have Mobitz type 2. We'll talk about 2-to-1 block in just a second. Remember what we said, Mobitz type 1 is a second degree AV node block that occurs actually in the AV node, okay? And it is affected by parasympathetics, okay? Whereas a Mobitz type 2 is a second degree AV block, and even though it's known as an AV block, the actual block itself is below the AV node. And as a result of that, there is no parasympathetic innervation, which can be helpful. We'll talk about that. So for a Mobitz type 1, because the block is more or less in the AV node, what do you think you're going to see? You're going to see PR intervals that get bigger and bigger as the block gets worse and worse. Why? Because the PR interval is made in the AV node. Secondly, because the block is fairly high up, your QRS complexes are going to be relatively narrow. So let's write it here. PR interval is going to be increased, and the QRS is actually going to be normal. As opposed to the Mobitz type 2 second degree AV block, which is below the AV node, it's relatively lower down. And so what you're typically to see here is the PR interval is going to be okay, but the QRS is typically going to be increased. Now, we don't see that here in this example, but that's just something you want to think about when you're looking at other examples if you want to differentiate. But the primary differentiation for a second degree AV block between a Mobitz type 1 and a Mobitz type 2 is this. And this is very important. This is probably the most important thing to know, is looking at the PR interval and noticing that in a Mobitz type 1, or a Wenckebach as it's known as, it gets longer and longer and longer. And you can see that here very clearly. The PR is getting longer, longer, longer. And then finally, what happens is you drop a QRS complex. In other words, it's infinitely long if you wish. Then it starts over again. PR interval starts over at the same length as it did at the beginning of the cycle. So we have a way of naming this. And this has to do with cycles and series. So we look at this ratio of cycles and series. So what is a cycle and what is a series? So the cycle is how many P waves are there. And in this case, there's 1, 2, 3, 4. So how many cycles would there be in this? There would be 4. We put a little line. And how many series are there? How many QRS series are there? In this case, there are 3. So the series is always going to be a number that's 1 less than the cycle. So this would be a Mobitz type 1 second degree AV block because the PR interval is getting increasingly longer with each cycle or series until finally there is a missing QRS complex. Because there are 4 cycles of P waves, we put a 4, and because there were 3 series that got longer and longer until finally 1 dropped, we put a 3. So this is a 4-to-3 ratio of a second degree AV block, Mobitz type 1 or Wenckebach. Okay? Now, what would happen if we did a vagal maneuver? If we did a vagal maneuver in this situation, that would increase the parasympathetic nervous system's drive to the AV node. So what would that do? That would make, in other words, this worse. The block would be worse. It would block it at the AV node because that's where this block is. It's at the AV node. So as a result of that, what you would actually see is you could have this 4-3 go to a 5-4. It would increase the number. In other words, instead of having 3 QRSs and missing one, you could have 4 or 5 or 6 and then have one that's missing. Now that actually seems better, but in fact, the QRSs are becoming increasingly more longer in length, and you would miss a cycle. So that's going to be an important differentiator when we talk about Mobitz type 2. So let's review on Mobitz type 1. Mobitz type 1, or Wenckebach, is a second-degree AV node block. It is at the AV node, therefore it is susceptible to parasympathetic activity. The PR interval becomes longer and longer with each successive cycle until finally the series ends and you have a missing QRS complex. Because it is innervated by the parasympathetic nervous system, if you stimulate that, how could you do that? By doing a Valsalva maneuver or a vagal maneuver. That would increase the parasympathetic drive to the AV node, and that would cause an increased blocking of this PR interval. Okay, so that's Mobitz type 1. Now, let's move on to Mobitz type 2. As we talked about with Mobitz type 2, this is technically at the AV node, but actually it's really below it. And as a result, it does not have any parasympathetic nervous system activity. Because it's not a block that is high up in the AV node, the PR interval is usually okay. But what you might see is an increased QRS complex. Maybe, maybe not, you might. So let's look here. These PR intervals are the same. They are not changing until finally there's a dropped beat. There's a dropped QRS, if you will. So this is far more serious because this means that the block is further down below the AV node. There's no escape mechanism from the AV node. You'd have to have an escape mechanism from further down in the bundle branch specifically. And in this way, we still get a missed beat. It's still a second-degree AV block, but it's below the AV node. Now, instead of naming it the same way we do up here, which is cycle series, we do it in a different way here. The way we measure it here is by looking at the block. So what we look at is how many P waves are there. 1, 2, 3, 4. And so the cycles is still the same. So in this case, it's 4. But then instead of looking at how many series of PR intervals get longer, we actually go the other direction and we ask how many missing QRS complexes are there. So in this case, this would be a 4-to-1 AV block, which would be a Mobitz type 2. And as we mentioned, no parasympathetic nervous system activity there because it is below the AV node. If we did a parasympathetic nervous system stimulation in this situation, a Mobitz type 2, which is a non-Wenckebach second-degree AV block, what would happen is we would block the AV node, which is not where the problem is. But actually, interestingly, what would happen is that the AV node itself would be slowed down, it would be partially blocked, and it would actually be more in line with the block that is below it that is causing the Mobitz type 2. So as a result of that, instead of making this worse, it could actually turn it from a 4-to-1 block to actually 1-to-1 conduction where you actually don't have a block. So that's an interesting distinction because what we could have, if time would allow here, we could have a 2-to-1 block. Now that's going to be very difficult because remember what we have here in Mobitz type 1. In Mobitz type 1, we're looking for increasingly long PR intervals. Well, what happens if the block is such that you get one conduction and then you don't get any conduction? And then you get one conduction, and then you don't get any conduction. In that situation, there are not enough series to see whether or not the PR interval is getting longer. And so when you have something called a 2-to-1 block, where you have the conduction of a PR, and then no conduction of a PR, and then the conduction of a PR, again, you're stuck. You don't know if this is a Mobitz type 1 or a Mobitz type 2, whether it's Wenckebach or not Wenckebach. And so again, you've got to look for those things that we talked about. If this were a Mobitz type 1, you would expect to see a large PR interval, and you would expect to see a narrow QRS complex. And if you look very carefully here, you can clearly see that this has a relatively large PR interval. And so just looking at this, you would say that this is probably most likely a Mobitz type 1 that's causing this AV block. Similarly, you would get a narrow QRS, which is exactly what you're seeing here. However, if it was a Mobitz type 2, which the block is below the AV node, you would not expect to have an enlarged PR interval. You would expect to have a normal PR interval. But you might see a widened QRS complex, which you're not really seeing here either. So this is a situation where you're suspicious that this could be a Mobitz type 1, but you're not sure. So what's one way you can differentiate this even more? And we've talked about it. It's doing a parasympathetic maneuver. Remember what we said again. In a parasympathetic maneuver, it would turn a 4-3 into a 5-4. So this could turn, in this case, it would be a 2-1. It could make it a 3-2 if it were a Mobitz type 1. Or if it were a Mobitz type 2, and we did a vagal maneuver, it should not affect it at all. So it would stay exactly the same, or as we mentioned, it could turn it into a 1-to-1 conduction. Okay, so why is that? The key here is that the parasympathetic nervous system activation is only going to affect a Mobitz type 1 because a Mobitz type 1 block is specifically dead set right into the AV node, whereas a Mobitz type 2 is below the AV node. That is the key. Okay, let's look at this example here. This is an interesting example that will test our abilities. Again, the best place to look at P waves is in lead 2. Here we see a P wave right there. Here we see a P wave right there. Here we see a P wave right here, but no QRS afterwards. So what we have, how many cycles are there? There are 3 cycles, okay? And how many QRS complexes? There are 2. But how many blocks are there? So if we thought it was a Wenke block, we would use this terminology, but if we think it's a Mobitz type 2, we would use a 3-2-1 block. So let's see which one it is. Remember what we said, that if it were a Wenke block, it would be at the AV node, and we would expect an elongated PR interval. So let's take a look at the PR interval first and see. Here we see the P wave starting right about there, and here we see the QRS complex starting right about there. That to me looks like it's at or below 1 box. If we look over here, you can see here's a QRS complex, it's the same one, and P wave there. That's less than a box. So to me, and when I'm looking at all of these, and they look pretty much about the same in this situation here too, that we have a PR interval that's not getting any longer and it's less than 0.2. So that to me makes me think that this is actually a Mobitz type 2 or a non-Wenke block second degree AV block. What was the other characteristic? Well, you know that the non-Wenke block or Mobitz type 2 is a block that is below the AV node, okay, even though it's classified as an AV node block. And as a result of that, your QRS complex is typically going to be widened. And certainly we can see here that that QRS complex and that one there, in fact, all of these QRS complexes are a little bit wider than we would expect. So again, here we have 2 things going for us that make us think that this is a second degree Mobitz type 2 or non-Wenke block AV node block. Now, interesting, if you look out here, what do we have? Now, this is a good example where you go from a 3-to-1 Mobitz type 2 block to a 2-to-1 Mobitz type 2 block in the same patient. We've got a P wave conducting a QRS, then we have a P wave with no QRS, then we have a P wave with a QRS, and then a P wave without a QRS. And this is basically identical to what we showed you before, except here we actually have the widened QRS. This is definitely a Mobitz type 2 with a 2-to-1 AV block. Very sure of that in this case. Okay, let's quickly review before we go on to the 3rd degree AV block. So we're looking at 2nd degree AV block, and we're over here the 2 types. So specifically, we've got Mobitz type 1 or Wenke block. Remember, it's at the AV node. There is parasympathetic. You're going to have PR intervals that are longer and longer and longer. Okay, and your QRS is going to be normal. Typically, these can be treated without pacemakers. Mobitz type 2 or non-Wenckebach, remember it's below the AV node, just below it. Because of that, the PR interval is actually going to be okay, but the QRS is going to be longer, perhaps. And here, because it's below the AV node, there is no parasympathetic activity associated with it. Okay, well, thanks for joining us. Join us on the next lecture where we're going to get into straight out third degree heart block.